This lecture is about the menstrual cycle and its disorders. I believe this is the most important topic in gynecology because if you understand the physiology of the menstrual cycle, you'll be able to recognize and manage its abnormalities. The menstruation is a woman's monthly bleeding from her reproductive tract induced by hormonal changes of the menstrual cycle. So it is monthly bleeding or periodic repetition of menstrual bleeding. This is the last sign of puberty, and this means that this female is mature and able to conceive. For menstruation to occur, we need a coordinated hypothalamo-pituitary-ovarian axis, responsive endometrium, and a patent outflow. All of these parameters must be present for the menstruation to occur. Hypothalamo-pituitary-ovarian axis interaction means that gonadotrophin releasing hormone will be released from the hypothalamus and stimulates the anterior pituitary to release follicle stimulating hormone FSH and luteinizing hormone LH, and we have steroids from the ovary, estrogen and progesterone. At birth, there are many primordial follicles that are frozen in the prophase 1 of the meiophase. By the age of puberty, and probably due to the effect of local androgens, these primordial follicles are changed into primary follicles. So the initial growth of follicles is independent of follicle stimulating hormone. Follicle stimulating hormone starts acting on the primary follicles, changing them into secondary follicles, preantral and later on antral follicles. Under the effect of FSH, these follicles start growing from the primary follicle, which is an oocyte with a single layer of cuboidal cells, to, as we said, secondary follicles. You can notice that there are multiple layers, single layer, then multiple layers of granulosa cells. And also note the formation of zona pellucida. Their estrogen also stimulates the formation of follicular pockets with fluid containing hyaluronic acid, and also stimulates the granulosa cells to produce estrogen. LH also is present at this level, and LH will stimulate the theca cells to convert cholesterol to androgens that seep through to the granulosa cells, and under the effect of estrogen, this androgen will be converted to estrogen, which is the two-cell, two-hormone theory. These cells will initially produce estrogen, and the highest amount of estrogen will be produced from the dominant follicle. Initially, with increasing amount of estrogen, there will be a negative feedback to stop FSH from stimulating further follicles, and later on, with more and more estrogen produced from the dominant follicle, there will be a positive feedback leading to LH surge and the release, ovulation, and the release of the secondary oocyte. The rest of the follicle will become the corpus luteum under the effect of LH, and it will continue producing the progesterone. If pregnancy does not occur, then this will become atretic and it will change to a fibrous tissue called the corpus albicans. To describe the menstrual cycle, we talk about the ovarian cycle and the uterine cycle. Ovarian cycle is composed of two phases separated by ovulation. In the follicular phase, as the name implies, there will be growth of the follicles, recruitment and the selection of a dominant follicle under the effect of follicle stimulating hormone from the anterior pituitary, and this results in the production of estradiol and inhibin B, with initially increasing estrogen, and inhibin B will lead to a negative feedback to stop FSH from stimulating further follicles, but later on with more and more estradiol, a positive feedback leads to LH surge and ovulation. With the release of the secondary oocyte, the corpus luteum will produce progesterone, and this is why we have the luteal phase. Ovulation means the release of a viable oocyte from the ovary, and every month one egg is released in humans, although occasionally two or more can erupt during the menstrual cycle. If there is no pregnancy, the menstruation appears exactly 2 weeks after ovulation. And this is to tell you that the luteal phase is always fixed at 14 days. As we said, in the follicular phase, a group of the most mature follicles, which are the antral follicles, are recruited, and only those who are the most sensitive to follicle stimulating hormone will undergo further development. The follicle which is most sensitive to follicle stimulating hormone will become the dominant one and continue to produce large amounts of estradiol and inhibin B. The remaining follicles will become atretic. The majority of the follicles will become atretic. Ovulation occurs 34 to 36 hours after LH surge, and this is important in our clinical practice. When we want to time ovulation for intrauterine insemination, we give HCG injection, which is similar in structure to LH, and time either intercourse or inject the semen 34 to 36 hours after ovulation, after the injection. In the luteal phase, progesterone will be produced from the corpus luteum, with the peak levels of progesterone attained 7 days after ovulation. And in clinical practice, when we want to test an evidence of ovulation, we do a mid-luteal phase progesterone, that is 7 days after the expected time of ovulation. The endometrial cycle starts by the withdrawal bleeding, sloughing of the endometrium in the endometrial phase. Then, under the effect of estrogen from the growing follicles, we have the proliferative phase, the growth of and regeneration of the functionalis layer of the endometrium, and the vascular growth. The proliferative endometrium is parallel to the follicular phase of the ovarian cycle. FSH stimulates the follicles produce estrogen, and estrogen leads to endometrial changes, growth and regeneration of the functionalis layer of the endometrium. Ovulation follows after LH surge with the release of progesterone from the corpus luteum, which leads to more proliferation, more regeneration of the functionalis layer of the endometrium, and vascular changes, more tortuosity of the vessels, and in addition to that, gland secretion of glycogen, lipids, and proteins, which possibly may be required for the nourishment for nourishing a possible pregnancy. And if you note, there is a residual reaction of the endometrium. In clinical practice, you may find residual reaction on a histopathology report whenever you have endometrial sampling for a lady who presented with abnormal uterine bleeding and receiving progestogens to control her bleeding. Remember, always and always, the second phase of the cycle is fixed at 14 days. The length of the menstrual period relies on the changes in the first phase, which is the proliferative or the follicular phase. The secretory phase or luteal phase is always fixed at 14 days. There are also cervical changes in the follicular phase under the effect of estrogen. The internal os will be funnel shaped and the mucus secretions, the cervical mucus, will be thin and watery with increased stretchability, and this is to allow the sperm to pass through, because every cycle will prepare the uterus for a potential pregnancy. In the second phase of the cycle, the cervix will be tightly closed and the mucus secretions will become thick and viscid and no stretchability, so that a mucus plug will be in the cervix to prevent any sperms from going through. Estrogen leads to proliferative changes of the endometrium, and estrogen dominant endometrium is unstable. This means estrogen withdrawal bleeding varies in the amount of blood, which can vary from spotting to heavy bleeding, duration, 1 day, few days, many days, and frequency. So estrogen withdrawal bleeding varies in amount, duration, and frequency. Progesterone leads to secretory changes of the endometrium and it stabilizes the endometrium, and this is why in clinical practice progestogens are the most important medication that we use to manage abnormal uterine bleeding. You can see initially there will be proliferation of the endometrium, some withdrawal bleeding, till there be another shedding and stabilizing the endometrium and back to normal bleeding. Where regeneration occurs, the endometrium is protected from the lytic enzymes in the menstrual fluid by mucinous layer of carbohydrate products discharged from the glands and stromal cells. So the menstrual fluid, it's not all blood, and this is why it's not called menstrual blood. It contains otolized functionalis because the basalis layer will not be shed out. This is from where regeneration occurs. So otolized functionalis, inflammatory oxidate, and blood. The blood will be from the rupture of the spiral arteries, which are branches of the uterine artery, a branch from the internal iliac, in addition to the proteolytic enzymes, and mainly we're talking about plasmin. Usually, the menstrual fluid is liquidy, but in the presence of high flow and rate, the clots will be formed because the proteolytic enzymes will not have the capacity to lyse all the blood. To recap, gonadotrophin-releasing hormone stimulates follicle-stimulating hormone to stimulate the growth of the follicles. The growing follicles produce estradiol and inhibin B. Increasing amount of estradiol initially lead to the proliferative changes of the endometrium and negative feedback. Estradiol and inhibin B will lead to a negative feedback to suppress FSH. With the growing follicle, the dominant follicle producing more and more estradiol, increasing amount of estradiol even more, there will be LH surge, positive feedback, LH surge, and ovulation. With the ovulation, progesterone will be produced from the corpus luteum, which leads to secretory changes, and this will continue under the effect of progesterone. If pregnancy occurs, then HCG will support the corpus luteum till the placenta starts functioning by 12 weeks of pregnancy. But if there is no pregnancy, then there is no HCG, and this corpus luteum will degenerate and change to fibrous tissue called corpus albicans. This is for the menstrual cycle. When we describe it, we should describe it in 4 specific parameters, which are the frequency, duration, volume, and regularity. The frequency of the menses or length of the menstrual cycle. The average length is usually 28 days plus minus 7 days, and in some references it varies from 24 to 38 days. Cycle length is the number of days from the first day of bleeding of the current cycle till the last day before the next menstrual cycle. The cycles usually tend to shorten with age, and they are irregular initially after the age of menarche in the first few years till there is maturation, and around the age of menopause the cycles will become irregular again because of anovulation. Duration means the number of the days of bleeding in a single menstrual period, and usually 8 days or less. The range varies according to the reference you're reading. According to this reference, the range varies from 4.5 to 8 days. It is considered to be prolonged if more than 8 days and short if less than 4.5 days. And as age increases, the duration of menstruation decreases. Volume is the monthly blood loss, and the clinical definition is usually subjective and defined as the volume of blood loss which does not affect the emotional, physical, or social and quality of life for a lady. The normal volume is between 5 to 80 milliliters. If it is more than 80 millimeters, we call this heavy menstrual bleeding or menorrhagia. Regularity of the menstrual cycle is cycle to cycle variation over 1 year, over 12 months. And this is why when we want to take a menstrual history, and if we want to know if these cycles are regular or not, it's inadequate to take 1 or 2 cycles. You need to take the cycle pattern over a whole year, and you check the differences between the cycles. The difference should be less than 7 to 9 days between the longest and the shortest. If the difference is more than 10 days, then we call these cycles as irregular. Menstrual disorders, we start talking about dysmenorrhea. Dysmenorrhea means painful menstrual cramps, and these are of uterine origin. Dysmenorrhea can be either primary or secondary. Primary dysmenorrhea, which is pain without organic pathology. It can be called intrinsic, essential, or idiopathic, and usually begins with the ovulatory cycles. So the initial onset is usually after menarche, 6 to 12 months after menarche, when the ovulatory cycles are established. And this is the most common medical problem in young. The cause of dysmenorrhea is not clearly understood. There are few theories to explain the cause of and the pathophysiology of dysmenorrhea. The first one, uterine contraction and vasoconstriction. Think of prostaglandins. The cause of dysmenorrhea is not well known, but there are few theories to explain the possible pathophysiology. The first one, uterine contraction and vasoconstriction. Disintegrating endometrial cells release prostaglandin F2 alpha, which is a myometrial stimulant and a vasoconstrictor. Prostaglandin F2 alpha stimulates prolonged myometrial contraction, and this leads to the reduction of blood flow and ischemic pain. Women with primary dysmenorrhea have an abnormal pattern of contraction with a higher basal resting tone. Elevated prostaglandins are usually found in the endometrial fluid in women with dysmenorrhea. Other factors implicated in dysmenorrhea include leukotrienes, vasopressin, and reduction of prostacyclin. Leukotriene leads to increased myometrial stimulation and vasoconstriction. Vasopressin acts through direct influence on myometrial blood flow and myometrial hypersensitivity, or via prostaglandin release. Prostaglandin is a potent vasodilator and myometrial relaxant in vivo, and reduction in the levels may lead to hypoxia, ischemia, and pain. Modulation and stimulation of pain fibers. The stimulation of pain fibers in the uterus causes activation of the afferent pain pathways transmitted up to the central nervous system. And in addition, there is some evidence of a direct effect on the pain fibers themselves in cases of dysmenorrhea. Vasoconstriction leads to ischemia, and it is thought that type C neurons are stimulated by the anaerobic metabolites by the ischemic endometrium. It is also suggested that leukotrienes increase the sensitivity of pain fibers. Psychological and behavioral causes. These can be related to personality and social factors and experiences gained from surrounding relatives. Dysmenorrhea is pain. Primary dysmenorrhea typically presents early after menarche. Usually 6 to 12 months after menarche. It could be later. It depends on the ovulatory cycles. Pain is usually cramping in nature and in the lower abdomen or pelvis, may radiate to the back or down to the thighs. Usually it starts with the onset of bleeding, and it's usually short lasting for 8 to 72 hours. Other symptoms may be associated as nausea, vomiting, fatigue, and secondary dysmenorrhea is pelvic pain associated with identifiable pathology, and it can occur at any time after menarche but may arise as a new symptom during a woman's fourth and fifth decades. Possible causes: endometriosis, adenomyosis, pelvic inflammatory disease, IUCD in the uterus, pelvic adhesions either due to endometriosis, pelvic inflammatory disease, or previous surgeries. Fibroids are usually associated with congestive dysmenorrhea. It depends where the fibroid is, on the position of the fibroid. Cervical stenosis and congenital abnormalities causing genital tract obstruction as non-communicating cornu. Keep in mind, secondary dysmenorrhea is different from chronic pelvic pain, where secondary dysmenorrhea can be related to the cycle. The timing of the pain can be related to the cycle, while chronic pelvic pain is present almost most of the time and cannot be related to the cycle, but probably both share the same pathology. Management of dysmenorrhea relies on explanation, reassurance, and simple analgesia. We can use prostaglandin synthetase inhibitors, mefenamic acid, with a maximum dose of 500 milligrams 3 times daily. We start with the onset of pain and during the bleeding days. The other options include cyclooxygenase inhibitor 1 and 2. We may use combined oral contraceptive pills to stop ovulation, and if the period is anovulatory, we expect no pain with the period. Mirena intrauterine system may be beneficial, but we don't usually use it in single patients. Other other options include paracetamol, hot water bottles may be helpful. If this is secondary dysmenorrhea, or if the patient's symptom does not respond to simple analgesia, then we need to consider laparoscopy to find a possible pathology and manage this pathology. If it is endometriosis, manage as for endometriosis, PID, obstruction, whatever the cause is, you manage the cause to manage dysmenorrhea. Now we talk about premenstrual. Premenstrual disorders should be used instead of premenstrual tension or premenstrual syndrome. Most women experience a certain degree of premenstrual symptoms before menstruation. These are counted as physiological when the severity of symptoms is not enough to have a serious impact on the quality of life, although noticeable by the woman. Symptoms usually occur in a cyclical pattern with a symptom-free week in the follicular phase after the period. So this is physiological premenstrual symptom, mild premenstrual disorder, where you see symptom-free week in the follicular phase after the menstruation, and increased symptoms in the luteal phase. Menstruation symptoms starts to improve 1 week free of symptoms in the for a week after menstruation in the follicular phase. If the symptoms are not cyclical, this means that you need to refer this patient for appropriate non-gynae treatment. Premenstrual disorders will lead to impairment of daily activities and will have impact on the everyday life of most of the reproductive years of a lady. The International Society for Premenstrual Disorders divide premenstrual disorders into the criteria for diagnosing core premenstrual disorders include, first of all, cyclical symptoms, and symptoms should resolve during or shortly after menstruation, that is 1 week free of symptoms in the follicular phase. Symptoms must be prospectively rated, that is, you ask the woman to document whatever happens with her in the next 2 to 3 cycles rather than remembering. Symptoms should not be an exacerbation of underlying psychological or physical disorder, and there should be an impairment of daily activities, including work, social activities, and family interactions. Core premenstrual disorder can be also divided according to the symptoms, if they are predominantly physical or psychological, or there could be a combination mixed both psychological and physical symptoms. Variant premenstrual disorders include premenstrual exacerbation, where there will be worsening of underlying medical, psychological, or physical condition as depression, diabetes, migraine, asthma, or epilepsy during the premenstrual phase. The symptoms will be present throughout the cycle with worsening before and reduction after menstruation. These disorders can be present with absent menstruation, as in cases of hysterectomy, can be induced by progestogens, as exogenous progestogens in HRT or hormonal contraception, and it can occur due to non-ovulatory dysfunction activity, but this is rare. There are more than 200 reported symptoms. To diagnose, the timing is very important and the symptoms should be prospectively recorded. As we said, more than 200 symptoms, whatever comes to your mind can be part of the symptoms, physical, psychological, or mixed physical and psychological symptoms. The exact etiology is unknown, but women often report a positive mood after menstruation, which probably is related to estrogen. And it is thought that the corpus luteum produces a symptom provoking factor, which is the progesterone. The concept of hormonal imbalance has been popular, but there is no supportive evidence, as hormonal profile was tested for women, for symptomatic and asymptomatic women, and there was no difference. Women with premenstrual syndrome are usually more susceptible to their normal ovarian hormones and especially progesterone. This increased sensitivity could be due to neurotransmitter dysfunction, possibly serotonin. Treatment is usually symptom-based strategy. If the symptoms are mild, start by explanation, support, reassurance, good nutrition, stress reduction, and exercise. If the symptoms are affecting the patient, then we either go for suppression of ovulation, or we may use the other option to treat without suppression of ovulation. Suppression of ovulation can be by using combined oral contraceptive pills. We don't use a gonadotropin releasing hormone analog because we use it for a limited duration of time, usually for 6 months only. Otherwise, if we need to use it longer than that, we need to give backup hormonal therapy, estrogen, because of the risk of osteoporosis. Danazol, we don't use it anymore because of its androgenic side effects. Estrogen again has side effects, and surgery, this is in extreme situations where we have to remove the ovaries to do a oophorectomy. Treatment without suppression includes selective serotonin reuptake inhibitors. We may also use diuretics. Non-pharmaceutical treatment includes herbal supplements, cognitive behavioral therapy, supplements as vitamin B6 and calcium, and exercise. Heavy menstrual bleeding is clinically defined as menstrual blood loss that is subjectively considered to be excessive by the woman and interferes with her quality of life. The other term that we use is menorrhagia. Menorrhagia is the same as heavy menstrual bleeding. It is an older term and it is defined as regular cycles with increased amount and or duration of the menstrual bleeding. This is a subjective symptom, and clinically you ask the patient about the use of pads, if they are soaked or not, if the presence of clots, duration of the menstruation, for how many days, more than 8 days, and it is the patient's opinion if she believes that there is a change in her bleeding pattern and she's having heavy cycles. The objective assessment does not improve clinical care. Usually, this is not used in our clinical practice. Weighing the pads, extracting heme to measure the volume of blood loss is done for research issues, but clinically, we don't do these things. If you ask about hemoglobin level, even if the hemoglobin level is normal, this does not mean this lady does not have heavy menstrual bleeding. If she's anemic, definitely this confirms the complaint, but if she's not anemic, this does not mean that she's malingering. Please make sure that heavy menstrual bleeding is a subjective symptom. In 40 to 60% of the cases, heavy menstrual bleeding idiopathic, and this was called dysfunctional uterine bleeding of ovulatory or anovulatory causes in the past. So when you don't find the cause, this was called dysfunctional uterine bleeding. Most heavy menstrual bleeding is due to a combination of causes, coagulopathy, ovulatory, or endometrial dysfunction rather than one cause. Pathological causes may include fibroids, polyps, adenomyosis, and for endometriosis, it rarely presents as abnormal uterine bleeding. The main symptom of endometriosis is pain, dysmenorrhea, secondary dysmenorrhea, or chronic pelvic pain. If abnormal bleeding occurs with endometriosis, it is usually premenstrual spotting rather than heavy menstrual bleeding. And gynecological malignancy rarely presents as heavy menstrual bleeding, usually presents with intermenstrual bleeding, postcoital or postmenopausal bleeding, or a pelvic mass depending on the malignancy. These are the old terms that you need to be familiar with. To start with a normal cycle, the length of a normal cycle, which varies from 21 to 35, or in some references, as I told you, 24 to 38. The length of the cycle is the number of days from the beginning of the period till the day before the next period. And the amount of bleeding is between 5 to 50 mils, and the duration is 8 days or less. If the cycle is regular, but with increase in amount or duration, then we call it menorrhagia, the same as heavy menstrual bleeding. Hypomenorrhea, when the amount, it continues to be regular, but the amount of blood loss is minimal and the duration is less than 2 days. Polymenorrhea, when you find the cycle length less than 21 days. So this means more frequent cycles. From the beginning of the cycle till the next, less than 21 days, we call it polymenorrhea. If the length of the cycle is more than 35 days, then we're talking about oligomenorrhea. This means infrequent cycles. And oligomenorrhea, whenever you hear it, remember polycystic ovary syndrome. Metrorrhagia, when we talk about irregular bleeding, we're not talking about the amount, we're talking about the frequency, irregular bleeding. Menometrorrhagia, irregular and heavy, irregular in timing and heavy. Please make sure you're familiar with the old terms. But the terms that we use nowadays is abnormal uterine bleeding. Abnormal uterine bleeding is any menstrual bleeding from the uterus that is either abnormal in volume, regularity, timing, or is non-menstrual, as intermenstrual bleeding, postcoital bleeding, or postmenopausal bleeding. So any bleeding which does not follow the normal pattern is called abnormal uterine bleeding. We've already talked about heavy menstrual bleeding. Intermenstrual bleeding means the uterine bleeding that occurs between two clearly defined cycles. Whenever you have intermenstrual bleeding, think of a cervical cause, and it could be an endometrial polyp. Postmenopausal bleeding is bleeding that occurs 1 year after menopause. Any bleeding after menopause is called postmenopausal bleeding, and women should seek medical advice. Postcoital bleeding, non-menstrual bleeding which occurs after intercourse, chronic abnormal uterine bleeding when the problem lasts for 6 months or longer, acute bleeding when bleeding requires immediate intervention to prevent further blood loss. All of these are under the umbrella of abnormal uterine bleeding. The International Federation of Obstetrics and Gynecology classifies the causes of abnormal uterine bleeding according to the palm coin. Palm coin. Of course, the most important, the most common cause of abnormal uterine bleeding in the reproductive age is pregnancy. So first of all, rule out pregnancy. Once you rule out pregnancy, think of the palm coin classification. Palm stands for the structural, polyp, adenomyosis, leiomyomas, malignancy, and hyperplasia. Non-structural causes, coagulopathy, ovulatory, endometrial, iatrogenic, and not yet classified. Examples of coagulopathy are thrombocytopenia, von Willebrand disease, leukemia, and those on warfarin. Remember, teenagers presenting with heavy bleeding and requiring blood transfusion, rule out von Willebrand disease even in the absence of positive family history. Disorders of ovulatory dysfunction as polycystic ovary syndrome, thyroid disease, hyperprolactinemia, endometrial disorders, iatrogenic for women on medications or because of a procedure or a method used for contraception as intrauterine contraceptive device, and there are the non yet classified rare causes as AV malformation. Postmenopausal bleeding is bleeding after menopause, 1 year after the last menstrual period. women should not have any episodes of bleeding, and if this happens, then medical advice should be sought. Causes of postmenopausal bleeding are usually due to endometrial atrophy, but our main concern is endometrial cancer carcinoma, and this is why whenever we do endometrial sampling for these women, our target is to rule out endometrial cancer. Intermenstrual bleeding, think of a local cervical or endometrial cause. Infection, endometritis, cervicitis, vulvovaginitis. It could be breakthrough bleeding for women using hormone replacement therapy or combined oral contraceptive pills secondary to examination or a smear test. It could be due to cervical or endometrial polyps. Cervical ectropion. Ectropion is the same as erosion, which is migration of the columnar epithelium from the endocervix to the ectocervix. It could be also pre-malignant cervical lesions, or it can occur naturally in 1 to 2% of women at mid-cycle in association with ovulation. Endometrial polyps are localized hyperplastic overgrowth of endometrial glands and stroma. These may present as heavy menstrual bleeding, postmenopausal bleeding, intermenstrual bleeding, and abnormal vaginal discharge. And they can be asymptomatic. We find them incidentally while examining the patient for another cause. They can be large or multiple in cases of subfertility. Diagnosis of polyps usually by doing an ultrasound scan, transvaginal scan, saline infusion, sonography, and hysteroscopy. Management is to remove in postmenopausal women, or if more than 1 centimeter in asymptomatic premenopausal women. If symptomatic, of course, the management is to do polypectomy. So, how to assess a patient when she presents with abnormal uterine bleeding? First of all, you have to take a history, do physical exam, have a differential diagnosis, request your investigations, then find or reach a final diagnosis and plan your management. When you take a history, first of all, take the history. If when she presents with abnormal uterine bleeding, take a bleeding history, detailed history of the abnormal bleeding and of the menstrual cycles, the current one and the previous ones. Compare the current cycle to previous menstrual cycles. Always ask about intermenstrual bleeding and postcoital bleeding, and ask about symptoms of anemia that reflect the severity of the bleeding. Other associated symptoms that may help you with your differential diagnosis are dysmenorrhea, congestive dysmenorrhea, as in cases of fibroids, secondary dysmenorrhea, dyspareunia. Usually we're talking about deep dyspareunia. Pressure symptoms, as in case of fibroids. Usually women may have urinary or bowel symptoms. Offensive vaginal discharge may be present in pelvic infections, but usually pelvic infections do not present with heavy bleeding. These usually presents with intermenstrual bleeding or postcoital bleeding. Of course, you need to know the effect, the influence on a patient's quality of life, past gynecological history, what method of contraception this woman is using. This bleeding could be either because of this method or due to failure of the method, and she's pregnant. This is a complication of pregnancy. Document and ask about the fertility plan, because your management will be affected by the patient's fertility wishes, and ask when was the last pap smear? Is the lady up to date with the pap smears? If she's up to date, when was the last one and what was the result? Previous obstetric history is important, and previous mode of deliveries, past medical history, especially if there is a pre-existing bleeding tendency, and similar family history, medications of anticoagulants. We're talking about warfarin. Also, tamoxifen is very important. Tamoxifen is used in the management of breast cancer. It has an anti-estrogen effect on the breast, but estrogenic effect on the endometrium. Women receiving tamoxifen should be followed up because of the risk of endometrial cancer. Other symptoms of thyroid as changes in weight, constipation and hair loss, past surgical history, risk of sexual transmitted infection, and family history of gynae problems. On examination, start by looking at the patient in general, checking her body mass index, vital signs. If acute abnormal uterine bleeding, she may have tachycardia, hypotension. Pale is one of the symptoms. Examine the thyroid, as the thyroid could be a cause of the abnormal uterine bleeding, and evidence of bleeding tendencies, bruises, or gum bleeding. On abdominal examination, look for scars of previous surgeries, look for tenderness or masses. Large fibroids may be felt abdominally. Pelvic examination, we start by a speculum exam to look for local cervical or vaginal lesions and assess the severity of the blood loss. Then we do bimanual examination to assess the uterine size, direction, shape, tenderness, and mobility. For example, an regularly enlarged uterus, think of adenomyosis. If it is irregular, think of fibroids. Limited mobility in cases of endometriosis and pelvic inflammatory disease. Cervical motion tenderness with adenomyosis, endometriosis, and pelvic inflammatory disease. Then we do an ultrasound. We always start by an abdominal ultrasound so you don't miss major pathology, followed by a transvaginal scan. This is good to identify fibroids, polyps, and in postmenopausal women, we measure endometrial thickness. We don't know the significance of endometrial thickness in premenopausal women. So in premenopausal women, whenever we do an ultrasound for assessing women presenting with abnormal uterine bleeding, our target is to look for a uterine cause, probably fibroids or polyps. Endometrial thickness is usually used in postmenopausal women, in women presenting with postmenopausal bleeding. 96% of postmenopausal women with endometrial cancer will have an endometrial thickness of more than 4 millimeters, and this is why 4 millimeters is the cutoff point that we use. Women with postmenopausal bleeding whose endometrial thickness is less than 4 millimeters still have a 1 to 2% risk of having endometrial cancer. So, whenever women present with postmenopausal bleeding, it is mandatory to do a transvaginal scan and measure endometrial thickness. If it is more than 4 millimeters, then we have to biopsy. What if the endometrial thickness is less than 4 millimeters? Then we do biopsy. If there are other comorbidities or clinical suspicion of endometrial cancer, then we have to biopsy. This is the saline infusion sonography, the same as a vaginal scan, but we inflate the uterine cavity with saline. This is a polyp without saline infusion, and you can see with saline infusion that the polyp is clearly identified. Blood tests start by doing a pregnancy test. First of all, rule out pregnancy. The most common cause of abnormal uterine bleeding in the reproductive age is pregnancy. Then do a CBC to check if the patient is anemic or not. Thyroid function is necessary, especially if there are symptoms suggestive of a thyroid disease. Clotting screens are not routinely required unless indicated by the history. Cervical smear is opportunistic, but it is mandatory, as in cases of intermenstrual and postcoital bleeding. STI screen, again, in cases of intermenstrual and postcoital bleeding. And endometrial biopsy is mandatory in all women aged 40 and more to exclude endometrial hyperplasia. But if women present with postmenopausal bleeding, we do endometrial biopsy to rule out endometrial cancer. Endometrial sampling can be done by one of three methods. It can be either done by a DNC, dilatation and curettage. We insert curette and get a sample from the walls of the uterus, from the endometrium. This is a blunt procedure, so we may miss pathology. While hysteroscopy and sampling, we insert a camera, visualize the uterine cavity, and obtain a sample from the abnormal area that we recognize. The third method is to do a PIPEL test, where this is again a blunt procedure, but this can be done in the clinic with the least convenience to the patient, and send all the samples to histopathology. Premenopause, our target is to rule out endometrial hyperplasia. Postmenopausally, our target is to rule out endometrial cancer. This is a picture from a hysteroscope where you can see the uterine cavity. These are the tubes, the openings, and in this you can see endometrial polyp. So you can remove this polyp easily. Treatment of abnormal uterine bleeding is medical and surgical. Medical, hormonal and non-hormonal. First line treatment is Mirena IUS, intrauterine system. The intrauterine system has a levonorgestrel, which leads to atrophic endometrium. So the blood loss will be reduced by almost 90%, and 1/3 of women may become amenorrheic 1 year after having the method inserted. The other benefit from the Mirena is that it provides contraception. And remember, we said that Mirena may be useful for the management of dysmenorrhea. So whenever you have a lady presenting with heavy bleeding and dysmenorrhea, and she wants a method of contraception, then Mirena will be the procedure of choice. Progesterone can be used in cyclical pattern from day 5 to 26, or from day 15 to or 19 to day 26. Depends on the abnormal bleeding. Is it heavy bleeding that requires 5 to 26 cyclical progestogen supplementation, or is it premenstrual spotting? Then we give premenstrual progesterone. Combined oral contraceptives are also used in the management of heavy menstrual bleeding, minimize blood loss, and also offer contraception if required. Non-hormonal include antifibrinolytic, tranexamic acid is used and it reduces blood loss by 50%. Non-steroidal anti-inflammatory, we talked about mefenamic acid earlier, which is used to manage dysmenorrhea. It is also associated with a 30 to 40% reduction in blood loss, and this is why it is a good medication to be used to manage dysmenorrhea and heavy menstrual bleeding. Surgical management includes endometrial ablation using various methods: thermal, resection, cauterization, and the other surgical procedure is hysterectomy that we use as an option when other alternatives are not beneficial. So whenever a lady presents with heavy menstrual bleeding, we give her options of medical, surgical. Medical, we have non-hormonal, non-steroidal, and tranexamic acid, or hormonal, intrauterine system. Mirena is first-line treatment, progestogens or combined pills, and surgery, endometrial ablation, or hysterectomy. The following scenarios will be discussed during our lecture time. Please have a look at them and think of the possible differential diagnosis for our discussion. Thank you.